So I'm very pleased to introduce Dr. Chris Gibbons, who is a professor of neurology at Harvard Medical School. He's the former chair of the Autonomic section of the American Academy of Neurology, past president of the American Autonomic Society, and past chair of the International Diabetes Neuropathy Consortium. He's also director of the Neurocutaneous lab at Beth Israel Deaconess Medical Center, and also director of the Joslin Center Diabetes Center Neuropathy Clinic. He's co-founder of CND Life Sciences, which is relevant to the topic we'll be talking about today. Dr. Gibbons is actively engaged in clinical and translational research. His current areas include developing novel biomarkers for neurodegenerative disorders, and also defining the mechanisms and pathophysiology underlying the development of neuropathy. He's received research funding from the NIH, including the NNDS and the NIA, the Goldberg Foundation, the Bion Family Foundation, and the Juvenile Diabetes Foundation. And his talk today, as you see, is titled, "Can Skin Biopsies Really Be Used to Help Diagnose Parkinson's Disease?" Chris, thank you.
So as the program said, we were talking about the gut and the skin, but I get to go first. So we know the skin's really important. This is almost a philosophical question. Can skin biopsies really be used to help diagnose Parkinson's disease? So I'll talk to you about that and maybe convince you, maybe yes, maybe no, we'll see. Before we go too far, if my clicker does work, which doesn't, we'll try this clicker. I just want to highlight a couple of disclosures, as David said. So the work we've been doing here at BI has actually developed some technology which has been licensed out to a company that we founded called CND Life Sciences, and it's been funded by a number of NIH grants. So we'll talk a little bit about that. But kind of back to this question, can skin biopsies be used to diagnose Parkinson's disease? So I've been thinking about this for a long time. And when you talk to colleagues or friends about this, the statements are usually, that's ridiculous. That's not really supportive, but that's the common statement. Followed by, you're wasting your time working on this. What are you thinking? Publish or perish. If you don't actually do something good, you're out of here. Followed by, you are a neurologist, right? This is a brain disease. What are you thinking? What are you talking about? So yes, these are sort of some of the comments from the early days of this discussion. And why do we think that? Well, many of you have seen pictures like this. So Parkinson's disease is a group of symptoms and signs that people have. And there's a whole host of things that happen. And whether it's a specific tremor that you're aware of, some slowed movement, some rigidity, problems with your bladder, with your bowels, dizziness, lightheadedness, maybe changes to your speech or handwriting, all sorts of things can go on. And in general, most people think that, well, you go to your neurologist, you get the evaluation, and you come out an hour later with a diagnosis, right? That's the easy part. Very simple. Why would this be complicated? But for many of you, the journey looks much more like this. We know that. We're the neurologists that are involved in this journey. We get it. It's not so easy. You go for tests. Maybe you have another evaluation. You go for more tests. You wait. Maybe you have a different diagnosis. Maybe it's the wrong diagnosis. There's a long time before you get from here to there. It's not easy. That's the challenge, right? So we all know that this is a difficult problem we face, and we're trying to figure out ways to get better. And why is it so difficult? So if you think about Parkinson's disease, this is a graph kind of over a long period of time showing an array of symptoms that people develop over time. That dotted line down the middle, that's where most of the time a diagnosis occurs. And that's generally when you have the full spectrum of Parkinson's disease, all the features that the neurologist can say, yeah, I think that's what's going on at this point in time. And that dotted line, if you really look to the left, there are a whole host of symptoms that you've had for years that you've been wondering about. So that can start with things like constipation. Maybe some of you have something called REM sleep behavior disorder. You're acting out your dreams, you're thrashing, you're fighting at night. These can occur decades before a diagnosis of Parkinson's disease. Maybe there's loss of smell. Maybe there's some urinary dysfunction or constipation, maybe some subtle tremor that you go to the doctor to demonstrate the tremor and it's never there in the doctor's office. And you're like, I swear I have a tremor, but it's not there. These are challenges, and this is why the diagnosis is so difficult over a long period of time. And despite that, one of the bigger problems is how good are we as neurologists? Well, if you see somebody with early stage disease, the accuracy of a neurologic examination is probably only 70%. That means 30% of the time we get it wrong. Even very late in the disease, after you've had this for decades, we're wrong 10% of the time in a specialty clinic, a movement disorder clinic. That doesn't talk about the general neurologist out in private practice, or for many people who can't even see a neurologist, the PCP. This is a really difficult problem. So that's sort of the backdrop to what we're thinking about and kind of what we're discussing. So getting to a diagnosis easily and effectively has always been a big deal. Now, what is this thing here on the screen? This is a protein. This is called alpha-synuclein. Some of you may have heard about it. It's linked to Parkinson's disease. It's 140 kilodaltons long, so it's a fairly sizable protein. And we all have this throughout our nervous system. It's throughout all the axons, throughout your body. Everybody has this. It's normal. We're supposed to have it. However, there are certain times where this protein may misfold. And if it misfolds, it starts to do things it shouldn't and causes problems. So there are a bunch of things with little P's up there called phosphorylation sites. That's sites where the protein may misfold. In most cases, probably 95% or more, it's at this 129 site. So it's called serine 129, it misfolds, but there are other places it can happen. But when it happens, the protein no longer does what it's supposed to. So this graphic is sort of giving you an idea of what happens kind of with alpha-synuclein. If you have it, which all of us do, and it folds into its proper shape, you make a paper boat out of it, it floats down the river, it kind of gets to the end, it's taken down, rebuilt, start over again. That's sort of the typical path of a protein. However, if it misfolds and forms a ball, and then it triggers misfolding of adjacent proteins, all of a sudden, these misfolded proteins start to accumulate. And when they start to accumulate, that's not a good thing. They start to stick around and gum up the works. All of a sudden, the machinery of your nervous system is not working the way it's supposed to. Things aren't happening the way you feel they should be. So this is where the problem really occurs. And this is the slide I like to torture our residents and medical students with. And I tell them they have 60 seconds to memorize this, and then we're going to quiz them. And I promise I won't quiz you on this. But this is sort of a diagram of the nervous system. And we think about the brain and the spinal cord shown here in the middle of the screen. You know, that's the disease that everybody thinks about when we talk about Parkinson's disease, right? It's a brain disease. All of this stuff on the outside, all these end organs, they all have nerves that go to them. But we don't really think of them in Parkinson's disease, although there's been a lot more talk about what we call non-motor manifestations of disease. So people know that there is involvement actually of the gut, of the salivary glands, of all sorts of different things that don't necessarily make a lot of sense to everyone, but it's there. And so this is sort of the idea that we've had, you know, if you look at this thing in total, it's not just a brain disease, it's a disease that's everywhere. And so a lot of research have been thinking about this. And so people have started to look for this protein, this alpha-synuclein, in different locations. People have looked in the spinal fluid, so you could get a spinal tap and look for this protein there. People have looked for the submandibular gland. You see a little biopsy right here. People have looked in the gut, doing colonoscopies and biopsies that way. So there are lots of ways that we can start to think about this, and lots of locations you could sample the tissue from. But if you look at this screen, there's all sorts of locations, and many of those I wouldn't necessarily be too excited about sampling. So there are a lot of places on the screen you probably don't want your physician poking around at. So where are places that maybe we could poke around that wouldn't be such a big deal? This little thing right at the bottom of the screen, there's a little side note here. That's the skin. The nerves go to the skin. They go everywhere else too, but the skin, that's interesting, right? We have a lot of skin. It regenerates, we can replace it pretty easily. So maybe the skin's an interesting place to look. This is a skin biopsy. For those of you who have had a mole or sun exposure and you've been to the dermatologist, this is your skin. This is your skin at the dermatologist's office with what we call a punch biopsy. They take a little tiny piece of skin. It's a little circular. It's almost like a punch hole that you see from paper. And you see the hole that's left here. It's very small. You don't need a stitch. That's a quarter next to it to give you a perspective on the size. So that's what you can take to get a piece of skin. But the question is, what does that actually tell you? You've got this little piece of skin now. What do you do with it? Well, it turns out that the skin has all sorts of really important information in it. So if you look at this core piece of skin, what do you have in there? Well, there are hair follicles, there are sweat glands, there are blood vessels, there are little tiny muscles called erector pili muscles that cause goosebumps. All of this is in the skin. And all of that, when you look at this image here, can be immunostained, kind of special stains that highlight where the nerves are in these structures. So you see these hair follicles and sweat glands and these blood vessels, they all have dense innervation and specifically autonomic innervation. And for those of you who've heard about non-motor manifestations of Parkinson's disease, it's the autonomic nervous system that's involved in all of that. So maybe this is a place to think about looking for alpha-synuclein. Maybe these autonomic nerve fibers in the skin might actually give us a path to detect this. So we actually started looking at this, and this is work from, we started doing this over 15 years ago now. It's been a while. It takes a long time to get from A to B. So our first publication was in 2013 on this, and we found alpha-synuclein in these peripheral nerves in the skin in patients with Parkinson's disease. And then we followed it up, with more research, and we identified that, yes, not only can we detect this in the skin, it actually seems to have some relevance to disease. If you have more alpha-synuclein, you tend to have more severe disease. So again, at least we were developing an idea that this was possible. Maybe we could do this. So if you're looking at the skin, what I'm going to show you are a series of pictures from different things. In general, nerve fibers are green. So anything in green is a nerve fiber. Anything in red is what we call phosphorylated alpha-synuclein. That's the bad protein. That's the thing you don't want to have. So anything red on this screen is bad. So you see some nerve fibers here, lots of red. That's bad. So this is a diagnosis of alpha-synucleinopathy, or a protein that's in here in the skin. For anyone who's red-green colorblind, sorry, these are horrible for you. Dr. Simon in the back's raising his hand saying, why do you keep doing this to me? So I apologize. But just to give you an idea, this is what we're seeing when we look under a microscope in the skin. So this is, interesting work. So we have these two publications, but where is the data leading us? So it turns out that other people began to have the idea as well and really began to look at this. And there has been an increasingly large body of work that's occurred over the last 15 years. And now there's a huge amount of data. So the good news is this has really become widespread. So there's a lot of people thinking about this, talking about this, and a lot of work being done. So this is just sort of giving you a smattering of the publications that have gone out there. So there is a lot of work behind this. And I'm going to give you a little bit of a glimpse of some of the more recent work we've been involved in. But I do want to get back to this philosophical question is, if you have this protein in your skin biopsy, do you have Parkinson's disease? Well, the answer is maybe. Why do I say maybe? Well, if you see this protein, you have this misfolded protein. That's not a good thing. We don't want that. But if you have it, it doesn't necessarily tell you you have Parkinson's disease, because you could have some form of Parkinsonism. Now, you've probably heard that term as well. That drives people crazy. What does that mean? Can't you just tell me? Well, there are some diseases like multiple system atrophy that has this same misfolded protein, or dementia with Lewy body has the same misfolded protein, or even pure autonomic failure. Or if you remember that timetable, we can see backwards in time, you might have that protein decades before you have Parkinson's disease. So you may have the protein and you may have Parkinson's disease decades down the road. We can't tell you necessarily that you have it right now just based on a piece of skin, but in combination with the clinical features that your neurologist is seeing, that can help inform what's going on right now. So that's a little bit of the discussion of conceptually why we can say you have protein together with the clinical picture, you have a disorder that we would call Parkinson's disease. Now, I'll talk a little bit about some of the data we have to say, why we think it's Parkinson's disease and why something else. So we had done some work trying to say, well, we know these two disorders, multiple system atrophy and Parkinson's disease, look alike in some cases very, very early on. But for those of you who haven't heard about multiple system atrophy, it's a scary disease. It's a very aggressive form of Parkinson's disease. People don't want it. They're very nervous about it, but they want to know because they need to plan. So we did some work to try and figure this out. And we studied a number of people with multiple system atrophy, with Parkinson's disease, where we had a bunch of controls. We do all sorts of tests that we always do in kind of these studies. And we did skin biopsies from the 3 locations on the body, the back of the neck, and then 2 sites on the legs. And we looked at this pattern of deposition of alpha-synuclein. And what we found was that in general, patients with MSA have much larger deposits in the skin than patients with Parkinson's disease. So the location actually was different. So people with MSA had a lot more distally, kind of lower part of the body. Parkinson's disease was much more up here. And if we actually looked at the amount in any given biopsy, these little dots on the screen are basically the amount of synuclein. So that shorter column on the left are people with MSA. The taller column on the right here are people with Parkinson's disease. The circles on the people with MSA are bigger. There's a lot more alpha-synuclein in any given biopsy. And if we just plot these 2 things, where it's located on the body and the amount, we actually get a real separation. So the kind of the black circles kind of with this whole pink grouping around it, those are people with MSA. And then people with Parkinson's disease are kind of the white circles in this kind of green band. But you can really see they separate. So we can actually tell the difference between these 2 diseases just looking at the skin as well. So for us, that was a pretty exciting step forward and allowed us to give a bit more information. Not only do you have a disease, maybe what type of disease you either have or may have in the future. Now, this, again, is never static. We keep trying to do new things. And so we've had a recent publication talking about alpha-synuclein deposition in all of the synucleinopathies. You remember I kind of mentioned there were a couple of different ones out there, not just Parkinson's and MSA. So we did a study where we looked at people with Parkinson's disease and multiple system atrophy, dementia with Lewy bodies, and pure autonomic failure. And this is a blinded study. So when the pathology comes to me, I have no idea what I'm reading. And then we had an expert panel. Every person who enrolled was evaluated by a team of specialists to really define, is this Parkinson's disease? Is this MSA? Is this something else? So it really gave us a very clear picture of what was happening. And these were our results. So to kind of give you a quick summary, if we take everybody who had one of these disorders compared to controls, we had a result with very high sensitivity, over 95%, very high specificity, over 95%. So what that means is if you have one of these disorders, we see this protein in the skin. If you're a healthy control, we don't see it in the skin with, over 95% certainty. So that was very good news. It looked like it was working. Now, if we look at the subgroups, the various things, Parkinson's, multiple system atrophy, dementia with Lewy bodies, or pure autonomic failure, we see that there are subtle differences. And actually, Parkinson's was the lowest sensitivity at just about 93%. And you may ask, well, why was it harder to pick it up in Parkinson's disease? Well, it turns out Parkinson's has more variability than all the other diseases. There are genetic forms of Parkinson's that we may not be able to pick up in the skin. They may not have these deposits. So there are some differences. And the other disorders don't tend to have these genetic variations. So that's one of the interesting findings we discovered. But what we found was that the patterns of deposition in the skin were almost exactly what we saw in the last paper. The MSA and Parkinson's differentiated quite a bit. And you see in dementia with Lewy bodies, this is the third one over here, we have a pattern that looks very much like Parkinson's, just a lot more of it. There's a lot more synuclein in the skin. And there's also a neuropathy. So there is a loss of nerve fibers. Now, people don't talk about, they don't have burning pain or anything like that. But if we count nerves there in the skin, there are actually less. So these patterns that are emerging in the skin biopsies allow us to start to separate between these different disorders just based on kind of where it is, how much. So this is beginning to give us, a significant amount of understanding about the disease itself. But one of the questions that comes up is, well, how do you measure this stuff? So you sort of look at this one on the left here, you see this nice big red band going through. How much is that? You compare to this over here with the stuff everywhere. How do you possibly count that? It's actually not so easy, particularly when you're doing biopsies and they're different, people do different depths and amount, so that it gets to be a complicated process of thinking, how do you measure something that could be highly variable, different locations, all sorts of variables there. So we really tried to tackle that question to provide an answer for how much synuclein you have. Because if we think about the future of clinical trials, if you have a new drug that's treating the protein, trying to remove it, you need to know how much you have and how much you have in the future to say whether something may be working. This is a really important idea. So if we can cut down the amount of protein you have in your skin, this may reflect what's happening in the rest of the body and the brain as well. So it's a really important concept. So we've spent a lot of time trying to figure out how to do that. So one of the things that's interesting is if you take skin and you put these bright colors on it, you get beautiful pictures, but these pictures fade on the glass. Immunofluorescence doesn't last. It's not permanent. You have about 6 weeks of really good data, and then it starts to fade over time. So we have to capture a digital image that's complete. And so technology actually has only recently allowed us to do this, where you can take a special image at super resolution and capture the whole picture with enough data that you can recreate the original, what you're looking at on the glass. It's not so easy, but technology's finally allowed us to catch up. And we also have this really interesting thing called artificial intelligence. And although many people have learned about ChatGPT and how to take your dog's head and put it on your body and look at and really make great pictures, there actually are some useful medical purposes for AI, and this is one of them. We've been able to teach our system to recognize what is skin, what is a sweat gland, what is a blood vessel, what is a nerve fiber, and what is a protein inside that nerve fiber, and then count it. And that's what we've been able to do. And then you can see here in the blue, this is what we call a heat map. So now we can display what's called a heat map on top of the image, and our pathologists get to have an easy button. They say, where's the alpha-synuclein? The bright red dots right up there. That's where you look. It's really easy to find it if you're pointing it out with a big red dot. So it allows us to detect this protein much more easily if you have it. And then we can come over here and you see these blood vessels, the nerve fibers wrapping around the blood vessels. These are all deposits of alpha-synuclein in the skin. And this tells us where it is and we can measure it and quantify it. So again, a big step forward if we think about how to be successful in clinical trials, because this is really kind of a major step forward. But getting back to the question of what do we do about it in an individual person? Well, now I can do a series of skin biopsies, the 3 skin biopsies we talked about, and I can get an output here. And you see these little dots at the top, these blue and yellow, these are deposits of alpha-synuclein in the skin in somebody with Parkinson's disease. I can look at this map, I can see where it's located. It's really not seen down here, down at the leg part. Now I can just glance at this and say, this is an alpha-synucleinopathy. This looks like Parkinson's disease to me. Why do I think it looks like Parkinson's disease? Because this is what multiple system atrophy looks like. This is different, right? There's no question. You glance at this, all of a sudden, it's a totally different perspective. And I can see from this biopsy, something very different is going on. There is alpha-synuclein all over the place, big, bright, angry-looking spots, a lot of alpha-synuclein. It is a more aggressive disease. Goes along with that thinking. So this is an important step forward we've been able to make. And what about comparing this to something like dementia with Lewy bodies? What's interesting here is we see a very similar pattern. The actual structures in the skin are different, though. It's not necessarily in the same blood vessels or piloerector muscles or nerve bundles. It's in different substructures in the skin. And I can glance at this and get this result as well. And so now we're starting to be able to quickly get data on not only how much synuclein you have, where it's located, what subdisease you have. This is allowing a big step forward for all of us in terms of thinking about this. So really kind of where we've gone to, it's, as you can tell, this is sort of a whirlwind tour, but it's been 15 years of work, which is kind of remarkable. We've been able to start to take this concept of looking in the skin. We can detect alpha-synuclein. We can see it in any of the synucleinopathies with very high sensitivity and specificity. And we can start to use these patterns and the amounts to separate between diseases and tell us something about the person that's in front of us. So this is, again, a big step forward. We're also now beginning to use this in clinical trials. We have a number of studies that are using this as an output to see whether the drug is potentially working. So as you imagine, this is work that's done by lots and lots of people. And so, in fact, we've had collaborators from around the country really helping us with all of these projects. They're big projects. We've had thousands of people involved in our studies at this point. It's a huge undertaking. So kind of, again, a lot of people have been involved. And just to give you the idea that this is a real thing, we actually last week were at an international expert consensus meeting on the use of skin for detection of alpha-synucleinopathies in Bologna, Italy. And we all met there. It was very exciting, very good food. But we all had a chance to sit and really kind of define what is it the field needs to do to really establish this as really a standard. And so many of you may have questions, and I'm happy to take time to do that. I think we have plenty of time, so we'll take questions, and I think hopefully David will help me for anyone online that may have questions. So thank you very much. Yeah, so the question really gets to, does alpha-synuclein change over time, and can we track this in clinical trials? So we actually just yesterday announced that we were awarded an MJFF grant to do exactly that. We enrolled our first patient just last week. So we are doing follow-up studies of 100 people with Parkinson's disease to look at whether it changes over time. So we're very excited to look at exactly that. We actually have data already in DLB and multiple system atrophy that, in fact, if we look at longitudinal follow-up, we can actually see the amount of synuclein increase fairly dramatically over time in these more aggressive diseases. In Parkinson's, I do anticipate it to be slower, but we do expect that, yes, we'll be able to see the amount increase over time. So there's an online question. I know there's other questions, but so the question online is, should someone have the skin biopsy to verify that it's PD and not one of these other diseases? And are the treatments different if it's one of these? So, that's an interesting question. So you're diagnosed with Parkinson's disease, but you're wondering, is it something else? Well, I think the general answer is, at this stage, we don't have separate treatments for these different disorders. We treat symptoms and signs of the disease. And so if you have rigidity or tremor and you're taking levodopa or Sinemet and you're responding very well, it probably isn't necessary to do a biopsy because you're getting the appropriate treatment and you're responding. If your disease is not responding, if you're receiving Sinemet and you're just not getting better, or things are rapidly progressing, maybe there's a question. And really, the question is what we're trying to answer. People can, of course, confirm that they have it with this detection with the skin, but it doesn't necessarily change the plan that's in front of them. For physicians who don't know, there are occasionally mimicker diseases, progressive supranuclear palsy, for example. It's a very different disorder, but can look very much like Parkinson's in the beginning. And that has a different trajectory. And that's a question where, again, if you sort of get to a point where something doesn't quite feel right, maybe it's not going the direction you and your physician think, that might be a time to evaluate. So there's no simple answer to that, but it's a really important question. It really depends on sort of the individual case. So there was a question over here, I think. So let me repeat the question. So the question is, there are GBA mutations in Parkinson's disease, one of the genetic forms, and there are drugs that are currently trying to see whether it actually works in that mutation, whether it in fact impacts alpha-synuclein. And the question gets to, can we see that in the skin? Is that possible? And we, of course, would be very excited to try and figure that out as well. We don't know at this point. We're just beginning kind of involvement in clinical trials. And so we don't know if a biopsy will change. We think that anything that's penetrating the nervous system, the drug and kind of removing alpha-synuclein, should do that in the periphery as well. That's our hypothesis. But to date, as you know, we haven't had any drugs that have worked. So we're still in the investigatory process. So we need to continue to work on that, but it is something we're very excited to dig into, because I think it is a really important step.
Let me just add one thing on that, because it happens, I also was a consultant for BL and helped to design this study. And I don't know if you know this, but I was advocating to use skin biopsies at baseline and later so that we could have used this trial to answer your question. But ultimately, for various considerations, they opted not to include that in the study. So I wish they had.
David didn't fight hard enough for us. No, but I think it is really important. And we're getting, and again, for many companies, it's sort of a big leap, right? It's a brain disease. We're looking at skin. It's a transition for a lot of the field to think about, is this, really real? So I know there's a couple of other questions online. So what if a person has Parkinsonian symptoms, but is negative on a skin biopsy result, right? That's an important question. So there are a couple of things to think about. If you have Parkinsonism, that means you might have Parkinson's disease or something else, and progressive supranuclear palsy was one of the other things on the list. Progressive supranuclear palsy is a tauopathy. It's a different protein. So it is possible if it's negative, that's leading you in a direction of a different disorder. However, the sensitivity in Parkinson's disease is only about 93%. That means 7% of the time we could miss it. And that could be because it's a genetic mutation that doesn't have one of these proteins kind of present in the skin that we can see. Or it's always possible that it's sampling error, right? As you can see that the dots that appear in the skin are in different locations, perhaps it just didn't capture it. So there is a risk that we could just miss it. So I think the primary direction you want to think about is the clinical pathway. If it's positive, it really helps push you in the right direction. If it's negative, it can also strongly push you maybe to different disease type. So that's sort of a way to think about this process. The question that gets to, there's someone in the UK who can smell Parkinson's disease. It's a really interesting idea. And the question is, does that have anything to do with what we're seeing in the skin? And the shorter answer is we're not sure. The longer answer is there are lots of changes that are happening in the skin. So these things that involve sweat glands change the amount of sweat production, change kind of the composition of that. So there may be actually a number of potential reasons that it's causing enough of a change in your odor that it is something that could be smelled. Again, it's a very interesting idea, and clearly somebody has that talent. I don't think we figured out how to expand that to the rest of us, but it's a really curious question. So unknown yet, to be followed up with. So let me jump back online for a moment here. So one question is, do you have plans? Do you plan to have any trials in people at genetic risk of Parkinson's disease to show how kind of early the abnormal alpha-synuclein shows up? So the answer is really yes. We're very excited to look early in the disease state. So we have 2 clinical trials going on right now. We're following 100 people with REM sleep behavior disorder. We're following them longitudinally to see how early can we detect the abnormal protein, and does that predict when they may develop a disease. So REM sleep behavior disorder has a very high penetrance. It means that if you have this disorder over about 15 years, it's a 90% likelihood you'll develop something like Parkinson's disease. So it's a very high risk kind of clinical phenotype. And we pick up alpha-synuclein in the vast majority of those people with RBD. So we can already pick it up at that early stage. We're also doing a separate clinical trial on patients with mild cognitive impairment. We're looking to see if subtle cognitive dysfunction can be picked up early and can be, in fact, in many cases, a synucleinopathy. Many may be Alzheimer's disease. So we're also doing the Alzheimer's biomarker kind of tests. So we're looking at both of these proteins to see if we can predict very early what somebody will have in the future. And so we're following them longitudinally to find out. So it's a very important question. Now, specifically, this was asking about genetic risk. We are doing some smaller genetic studies. These are much harder, of course. So finding people who have a family history of Parkinson's before they have any symptoms is really what we're trying to identify. And that's a really hard group to get a hold of. There are some studies that are going on about that we're just beginning to get involved in. So hopefully in the future, we'll be able to answer that with more authority. There's a question in the back over here.
Thank you. I'm just wondering, you mentioned PSP a couple of times, but you kind of away from it, what's your thoughts about the tool diagnosis of PSP?
So in this case, the skin biopsy would not show any alpha-synuclein in PSP. And so that's how it helps to differentiate. So for many people, they may get a DAT scan if they're looking for the diagnostic kind of pathway. And the DAT scan may be abnormal in PSP and Parkinson's disease. So the skin biopsy, however, would not be positive in Parkinson's disease. So in that case, it would help. I'm sorry, yes, in PSP, my apology. Yeah, so that the biopsy would be negative in PSP and to kind of move you in that direction. So again, it helps to sort of move you, a negative result can move you in that direction. So a few others online, let me just grab those. And this is an interesting question. Wouldn't it make sense to have this test before DBS? So that's an important question. We don't know. We think it might be important. We do know that patients with MSA and Parkinson's disease do very differently. And so if there's a question there, we think that might be really important. Those are studies we haven't done yet. So it is an important question. And we're trying to look into that further. So, as you can tell, there's a lot of questions out there. We're trying to juggle many, many competing questions to figure out what we can do. And then there's one question down here. I had the skin biopsy test in November of 2022, and I was told it showed I have PD. How do I get the results of that test? So you should have those results of the test, from your physician. They received a copy of the results, and they should be able to share that with you. Certainly follow up afterwards with me. I'm happy to kind of make sure that whatever happened there, that is available to you if you did not have that. And I guess the question would be if it was in a research trial. Sometimes the research study results take longer. They have to close the trial out. So that could be a different question. Yeah. So then is there a difference, the current skin biopsy test compared to test on last year, and whether a repeat test is useful? So the results will be the same in terms of the test kind of technique. And so they are comparable results. So the test hasn't really changed at all. That's the question. Any other questions here in the group? I'm sort of reading. Oh, one up front. Yes. So essential tremor is an interesting problem. There's a lot of concern about, I have a tremor. Is it essential tremor? Is it Parkinson's disease? So we actually, or you could have both. And that's actually the point that I was going to mention. We are doing a study with Joe Jankovic, and who's very famous in kind of the essential tremor space, because there is a very high risk of Parkinson's in people with essential tremor. In fact, 10 times the risk of the general population. So it's not insignificant. So it's a group that we're studying because we do think that essential tremor in isolation should not necessarily have alpha-synuclein. However, there is a huge group of people who are at potential risk of overlap disorders, where they may go on to develop Parkinson's disease. And in those cases, yeah, we do think those are potentially positive. So in our study thus far, we've seen about 30 to 35% of people with essential tremor are alpha-synuclein positive. And we think those are the ones that are going to go on to develop essential tremor that's morphing into Parkinson's disease. We don't have all the data yet. It's still ongoing. We actually we had submitted a very large NIH grant for this to really study a population level. We got a good score, so we're excited that hopefully it will be funded. So we'll have more to come on that one as well. And then online, can you have Lewy body disease and Parkinson's in the same person? So this is an interesting question. So Lewy body disease and Parkinson's disease are both what we call Lewy body disorders, because you have this alpha-synuclein protein in your brain, in neurons, and that's called a Lewy body. And when it's in a axon, the long part of the nerve, it's called a Lewy neurite. Unlike multiple system atrophy, where you don't see that protein there, it's in other nerves in the brain called glial cells. And so they're kind of separate patterns, but Parkinson's disease and dementia with Lewy bodies are sort of two ends of a spectrum. And Parkinson's disease can develop cognitive impairment and to move to Parkinson's disease with dementia, which can really phenotypically look exactly like Lewy body dementia. So they sort of end up meeting in the middle. And it may simply be that where is this alpha-synuclein at any given time? Where is it spreading to? There are differences depending on where you start from. So if you start with the cognitive complaints, we call it dementia with Lewy bodies. If you start with the movement, we call it Parkinson's disease, but there's a lot of phenotypic overlap. And I don't know, David, if you have any additional thoughts on that, but it seems like this is, an ongoing topic. The Movement Disorder Society had a big debate about whether they're the same thing or not, and they've sort of put a moratorium on making a decision. They said we need more data.
Yeah, and I thank you. I see, and there's a lot of other good questions in the chat. I'm glad we had time to answer some of them, but it is time to move on to the next talk.
Yes.
So thank you very much. Very interesting.